We have Mrs. Ahlam, a 59-year-old female with a month history of headache. We did a brain MRI for her and it showed a 3 centimeter ring enhancing mass in the left frontal area, and the biopsy confirmed WHO grade 4 GBM, and last week we did for her a maximum surgical debulking, and we're here today to review the histopathology.
Yes, indeed. I have the report in front of me, and specimen did indeed contain a 2.5 centimeter glioblastoma multiforme. We also have done rapid testing and revealed IDH1 mutation as well as MGMT promoter methylation.
Okay, that's excellent. So, do you have any suggestions for adjuvant treatment?
Less than 10% of the individuals with GBM carry an IDH1 mutation, while about 60% of grade 2 to 3 gliomas are IDH-mutated. IDH-mutated tumors are associated with a more favorable prognosis. Epigenetic silencing of the MGMT gene promoter suggests a partial inability of the tumor to repair the chemotherapy-induced DNA damage. MGMT methylation confirms a better prognosis, and it predicts for a good response to temozolomide. Concomitant and adjuvant temozolomide chemotherapy, in addition to radiotherapy for newly diagnosed glioblastoma, resulted in a clinically meaningful and statistically significant survival benefit, and is the current standard of care for patients with GBM up to the age of 70 or fit elderly patients. In less fit patients, temozolomide alone as adjuvant therapy can be considered.
We have Mr. Ahmed, 65-year-old, fit and well gentleman, and he presented with 2-month history of headache, for which we did a brain MRI, and it showed a left temporal lobe ring enhancing lesion suggestive of glioma. We did for him a maximum surgical resection about 2 weeks back, and we're here today to discuss the pathology.
So the surgical specimen contained a 4 centimeter mass consistent with anaplastic astrocytoma. Molecular testing was done and showed absence of co-deletion of 1P-19Q.
Thank you, Dr. Ali. Do you have any suggestions of adjuvant therapy?
We'll ask our oncologist friends there.
Two phase 3 studies demonstrated a benefit of adding chemotherapy to radiotherapy in patients with anaplastic oligodendroglioma or oligoastrocytoma who harbor the 1P-19Q co-deletion postoperatively. In view of this, the current NCCN guidelines for patients with anaplastic astrocytoma and anaplastic oligoastrocytoma who have a good performance status and do not harbor the 1P-19Q co-deletion are fractionated external beam radiotherapy followed by adjuvant temozolomide, fractionated external beam radiotherapy with concurrent and adjuvant temozolomide, fractionated external beam radiotherapy with neoadjuvant or adjuvant PCV.
We have Mr. Naji, who is a 70-year-old gentleman, and we did for him a maximum surgical resection for a 5 centimeter GBM, which was found MGMT methylated. I talked to him about radiotherapy, but he strongly refused any radiation therapy. I wonder what else we could do for him.
He's a bit old, isn't he? How fit is he?
I wouldn't say that he's extremely fit. He's not very well. He requires occasional assistance, and but he's able to care for most of his needs.
Well, I guess this will put him at a confers performance of around 60. I think the decision has to be made with utmost care.
With the poor performance status and age over 70, chemotherapy alone is a fairly reasonable option for this patient. This is especially true given that this tumor is MGMT methylated, which predicts for a good response to temozolomide. One phase 2 study of temozolomide in patients with newly diagnosed GBM more than 70 years of age who had a post-operative Karnofsky performance score of less than 70. The median progression-free survival was 16 weeks and the median overall survival was 25 weeks. The other options for this patient are hyperfractionated brain radiotherapy alone or palliative supportive care.
Can I ask you about the patient next door? His name is Fadi.
Yeah, sure, go ahead.
Well, actually, he's a 55-year-old male patient, and he was diagnosed with a stage 4 squamous cell carcinoma of the lung. BDL1 is 10%. Outside of the chest, the disease he had is a solitary brain lesion in the parietal lobe, about 3 centimeters in size. And actually, this patient is known to have ulcerative colitis. He is taking steroids, so immunotherapy was not given to him. And now he's doing well after he was started on chemotherapy, Taxol and carboplatin, except of headache. So I was wondering if there is anything else that we could have done for him, right?
And instead of cheating from a paper, you should have looked this up. What do you think we could give him?
For patients with limited systemic disease, with a limited brain metastases, aggressive management should be considered. Limited brain metastases defines a group of patients for whom stereotactic radiotherapy is an effective treatment and offers significant cognitive protection compared to whole brain radiotherapy. The decision to resect a tumor may depend on the need to establish a histological diagnosis, the size of the lesion and its location. Smaller, less than 2 centimeters, deep, asymptomatic lesions may be considered for upfront stereotactic radiotherapy, while large, more than 2 centimeters lesions that are symptomatic may need to be treated with surgery. For surgical candidates, stereotactic radiosurgery can be offered as an adjuvant therapy, while whole brain radiotherapy is not recommended in this setting. The NCCN guidelines state that if a systemic therapy has a robust central nervous system penetration, for example, alectinib in ALK rearrangement positive non-small cell lung cancer with brain lesions, it is reasonable to hold off radiotherapy or surgery to see if the systemic therapy can control the brain metastases first.
Mr. Ahmed, thank you for coming today to the oncology clinic to talk about your treatment after surgery. How are you doing today?
Well, I'm fine. Thanks so much. I'm recovering well from the surgery and just looking forward for the next step.
Well, actually, we have discussed your situation in and out in the MDT, and we have decided that the best course of action after the surgery is to give you chemotherapy with radiotherapy, which we call a chemoradiation. And the treatment that we are going to use for chemotherapy is a tablet that we call temozolomide.
Temozolomide, okay, chemotherapy. Right. Well, see, doctor, I'm happy to go with whatever you advise, but I have to tell you that my brother just recently undergone surgery for his colon cancer, and he was given for surgery a drug called Xeloda, for which he had serious reaction. He's currently in the hospital being treated from the side effects, and I think he was told that he does have a mutation in a gene called DPYD, something like that. And I'm not sure really whether this drug that you're going to give me is the same as the Xeloda, and whether I need to be checked for this gene mutation at all.
Dihydropyrimidine dehydrogenase is an enzyme made by the liver that plays a role in the thiamine and uracil metabolism. Uracil is an important part of the drugs 5-FU and capecitabine. 2 to 8% of the population have a partial DPT deficiency, and those may have severe side effects if they were treated with the standard full dose of either 5-FU or capecitabine. Temozolomide is an oral alkylating chemotherapy drug. Hence, DPT deficiency is unlikely to result in any increased toxicity with administration of this drug.
We hope you liked our video. This is Acting for Clinical Education.
And don't forget to check the reference down below.
Please like, share, and subscribe. And don't forget to join us every Thursday, 5 p.m. Greenwich time.